Brilliant. Thank you so much. Well, I'm really grateful to be here today, and I understand you're running a little bit late, so I will be very careful with my timings and make sure that I'm done on time. As I said, I'm James Fallon. I'm joining you from Brighton and Sussex Medical School. I'm very sorry that I couldn't be with you in person, and I'm also sorry that I only speak English, which is awful. So whilst I've seen bits of your conference, I haven't been able to understand most of it, but what I've been able to understand has been excellent so far. And in fact, I've seen you had some really good content around antipsychotics already, so I hope this will serve as something helpful to sit alongside that. Just a little bit about me. The reason why I'm talking to you about this today, I was an early intervention in psychosis consultant, and that's when I undertook this piece of research. I currently work in a team called the Assertive Outreach Team. So I only work with people with psychosis. I don't do any other conditions, comorbidities only. And as a declaration of interest, well, I don't have any. I'm not paid to do this research. I've got my own reasons why I want to do it, but I don't get paid to talk about these things. So I'm doing it out of my interest only. And where do we conduct this? The stuff I'm going to talk to you about today, well, in Sussex in UK, which is on the south coast of England, which is a bit of a mixed area. It's relatively large as counties go, about 1.6 million patients there. And there's pockets of deprivation, but overall, it's quite a wealthy region. So what are our big questions that we wanted to answer? Well, the question was, do specialist early intervention and psychosis services prescribe differently to generic services? So in the UK, we have a specialist service set up, which I'm going to talk to you about, for people who have their first episode of psychosis. And the idea here was, if the specialists in dealing with first episode of psychosis are choosing different medications to treat patients with to those who aren't specialists, then why is that? Why aren't we working in similar ways? And why aren't people perhaps working in a way that the specialists are? And then the other big question was, if we start a patient on an antipsychotic on day one, do they stay with that over that first year? Because that first year is really important in terms of long-term recovery. So I think to do justice to this, now I'm conscious that there will be a range of people in the audience, and there'll be people with phenomenal understanding about first episode psychosis, there'll be people who really understand all the various models of care, but what I'd like to do is cover a bit about how services work in the UK and what early intervention in psychosis is, the model that we use in the UK, just in case anyone isn't familiar with it. I'll talk about how we ran the study, the results, and what they might mean. So as a bit of background, most antipsychotics, with the exception of clozapine, are created equal. We know, and you can dig down into individual studies and they'll show a minor advantage in one domain here and a different one will show something else. Truthfully, I'm not convinced by the collection of all of them to say, wow, we could really say that this antipsychotic is much, much better than any of the others, except for clozapine. So when we choose our initial antipsychotics, the National Institute of Clinical Excellence, which is who writes the guidance in the UK, say it should be patient choice and individual response and tolerability. But we know, don't we, that we've all got our favourite antipsychotics or medications in general, and that's what we're interested in. What we're interested in with this piece of research that we did is, now look, what are the prescribers' preferences and potential biases? But why does that matter? Why does it matter to get about the first ever antipsychotic? If they all work as well as each other, does it really matter which one? Well, I would say yes, because if you get a good starting experience with an antipsychotic, then we should, if we get side effects, we should carry on taking it. And that's really important, because treatment for at least 12 months is going to reduce the risk of relapse, and it's going to reduce that risk of progression to chronic illness, because we know recovery rates in first episode psychosis are actually pretty good. Another part of the study that we did was looking at diagnosis, because actually, if as many as 40% of patients with psychosis don't have a further episode of psychosis after their initial episode, well, in that case, why would we give them a diagnosis of schizophrenia, for example, if it's not a chronic progressive illness? So those first 2 years do seem to be predictive of how you'll do. If you don't have further episodes in that 2 years, you've got the best chance of never having another episode. If you relapse and remit over those 2 years, then it's likely to follow that path. And if you don't get better, then the chronic progressive schizophrenic type illness is likely. So with that in mind, Get it right first time. Get them on the right medication for them, one that they tolerate, that they'll stick with. Get those in that initial year, and if you can get 1 year, you normally can slowly reduce over the next year, has been my experience, and you'll get the best possible outcome. So let me talk a bit about how we work in the UK. Everything is used through the National Health Service pretty much. There's a bit of private practice, but they don't do this side of things. They don't do psychosis really. Referrals typically via general practitioner, and it's very community-based. You can see we've lost 5,000 beds in the past decade, so it's very community-orientated. And I put this up, and I don't expect anyone to really, follow this, but this is how services are structured. It's very complicated for a clinician to navigate, awful for patients, really, very tricky to find your way around this. So the ones, I've starred the ones that we're interested in. So, the general community teams, the people running outpatient clinics where the community nurses are based, the inpatient services, so the hospitals, and then down in the bottom left, the early intervention and psychosis service, that specialist service that's set up specifically for first episode psychosis. And we've got a very strict process with early intervention services in the UK. You have to see people within 2 weeks, and anyone can refer. What does that mean? Well, it could be their general practitioner, their family doctor. It could be a school. It could be a university. It could be a family member or a carer. It could be a concerned friend. It could even be the patient themselves, although that usually is a bit of a clue. They probably don't have psychosis because most patients with psychosis don't recognize it. And what's the point of this? Well, we're trying to reduce the duration of untreated psychosis. So I'm trying to relate things to Egypt as much as I can. We can see, that in the UK, a big push in this early intervention model is about going out and trying to track down people who are in the early stages of psychosis and treat them very early. And there's been a range of studies that have happened in Egypt, and I'm conscious that there have been, I've kind of put the two further ends of the ranges there. And the idea is to improve functional recovery. And you get a 3-year period of this intensive support, and it's an intensive multidisciplinary support, all evidence-based. You've got small caseloads. So for when I worked in northwest Sussex as the doctor working 3 days a week, I had about 70 or 80 patients that I cared for, which is very low, really, because each of those would then, the person they meet with most often would be a nurse, social worker, occupational therapist. And the model doesn't just involve medications, that's what I'll talk to you about today, but it's got all these evidence-based approaches, cognitive behavioral therapy, family interventions, carer support, thinking about functional improvements, so education, employment, physical health assessments and well-being. And it's very, very cost effective because patients don't relapse so often, they don't need crisis contacts, hospitalization, and actually you can, in the area I worked where you'd expect about 50 cases a year, the 4-year savings were absolutely huge. And that's after you paid for the cost of the service. So, but the reality is that most of the patients who get started on antipsychotics won't be picked up by the early intervention service. Most of them will be picked up by the inpatient, the hospital teams, or the generic community teams. Patients will be referred in to the community team, be seen there, picked up their psychotic, put on treatment, and then they hand over the treatment for 3 years to the specialist early intervention service. So these services, which I call non-specialist, which I don't think is fair because they're specialists at what they do, but the services that aren't set up specifically for first episode psychosis start most of the treatments for patients with first episode psychosis. So that's why we want to see if there's a difference in the way in which they prescribe. Do different care teams have preferences for their first ever antipsychotic they prescribe? The first thing they write down on the drug chart, the first prescription that they issue. Does that change over that first year? Do they stick with it for the first year? And does the age, gender, or the ethnicity of the patient influence clinician's choice? So normally when I do this, and I like to do this with our students, and I say, well, which of these antipsychotics would you choose to take? Which would be on your list that you'd go for? And I know which one I would choose. And I always say to them, well, if there's medications there that you wouldn't choose for yourself, you need to have a really good reason why you're choosing to prescribe them for your patient. That doesn't mean don't prescribe them, but you really need to think, why am I choosing this for my patient if I wouldn't have this one myself? Again, these side effects are not stuff that will be new to you. The service review design, we had 494 patients on our caseload throughout the whole of Sussex. And of those, we only wanted to work with people, we only wanted to look at people who'd had a year full of treatment. So that was, it got down to 274. And as you'll see down here, the majority of those prescriptions were started, the first ever medication prescribed was started by community or inpatient services. So already we know they're key. What are the demographics? Well, a real surprise to me here, because actually it turned out that in the hospitals, so the most acutely unwell patients were predominantly female, which came as a surprise to me, because we always think of the most psychotic people as being male, don't we? And the community teams seemed to be much better at picking up psychotic men in a specialist early intervention service. What about ethnicity? No great surprises here. We know that black and minority ethnic people are much overrepresented in terms of psychosis diagnosis, and that's what we found. So let's look at some results here. Do the teams prescribe antipsychotics preferentially? Well, this is pretty striking to me. I think the answer is, yeah, well, look, the community teams and the inpatients are very much in keeping with each other, aren't they? 65% of them were prescribing olanzapine to their patients with their first episode of psychosis. So first time they've ever been psychotic, here's olanzapine. To me, that high number indicates that that's just the one that they naturally reach for. What about the specialist service? A bit more of a spread there, actually. We've got, very, very few patients started on olanzapine by the specialist service, and much more started on aripiprazole, with a spread of quetiapine and risperidone. So to me, just looking at those is pretty striking, but when you go and do the analysis of the data, you find that there is a preference for olanzapine with community and inpatient services, a statistically significant one. And this is just it represented in a slightly different form, but you can see that in the second one here, the olanzapine, you can just clearly see that there's that preference there for that in community, generic community teams and inpatient teams. And that's it. There were some other ones, just to show you that there were other ones in there as well, but we picked out the big four because they were 95% of the prescriptions were aripiprazole, olanzapine, quetiapine, and risperidone. So, did patient demographics make a difference? Well, good news, age and ethnicity didn't, but we did find this, which I found interesting, was that women were more likely to be treated with olanzapine, which is a very sedating medication, as you know, lots of weight gain associated with it as well. But I did wonder if this was down to kind of the potential later diagnosis. If we were having a lot of women into inpatient units unwell with affective psychosis, say manic episodes with psychosis, this might represent the desire to use something sedating to restore sleep. Then we looked, does the choice of antipsychotic change over that first year of treatment? Well, it did. So 67% of patients had switched or stopped taking the initial medication. And that was, you can see, for patients on olanzapine, only 17% of them stayed on that at the 1 year mark. So the vast majority of patients started on olanzapine have stopped it by 1 year, which indicates to me that that doesn't feel like that was a good long-term treatment for those patients. And this is what, for the full cohort, that 274 patients, this is what the prescription rates were. And you can just see that in that green one there, that's the olanzapine, that's really shrunk down. And olanzapine is a very small proportion now, whereas aripiprazole has remained consistent. And we have seen that there's been drop-off and that some of the patients have stopped taking it. Just under a third of patients have stopped taking antipsychotics. Having said that, I will say from working in early intervention psychosis services, working with people with psychosis, that's not, I don't think that's too bad. We'd like to improve that, but the majority of people remained on an antipsychotic at 1 year. And importantly here, I'll just draw your attention to the fact that there was a significant association here between the initial medication and whether it was continued, with aripiprazole being the most likely to be continued and olanzapine, and I did that. So what happened? So of the 274, 213 had stopped the original antipsychotic prescription and moved on to something else, or entirely stopped, and 75 had stopped. So there's a lot of changing of antipsychotics in that first year of treatment. How does this compare to other research? Well, there's not a lot of research in this area. If you look at Keating et al., they wrote a paper about in Ireland, and 80% of first episode patients were put on olanzapine, which doesn't feel very tailored to me. If you just only use olanzapine, it's not a tailored approach to your patient. And they've got really quite forceful in their conclusions around how they felt this was not acceptable because of the side effects. And then if you look at a one that was done in Sussex, again, and Warwickshire, a slightly different study, you can see that preponderance for olanzapine. And even in overseas, in Seoul, olanzapine was 34% of prescriptions, but had dropped between 2005 and 2010. And they did theorize that that was down to the fact that it had been, the metabolic side effects were responsible. I couldn't find, and maybe one of you will be able to share with us, which would be really helpful, the prescriptions, the initial choices, preferences in Egypt, but I did get this study, which I thought was quite helpful, which just shows that the majority of people felt that your first line antipsychotic for a patient would be an oral atypical, which I think is probably my preference. Now, this isn't first episode psychosis specific, and in fact, we've said schizophrenia here, or they've said schizophrenia, which indicates not first episode. But cost is an issue, and I have no idea, guys. I really apologize because I only had Google to rely on. But the difference in price, these are quite expensive medications, in my view. In the UK, we're fortunate in that most people with psychosis wouldn't have to pay for their prescriptions, and our national drug tariff is very low because they've negotiated the price down very effectively. But this seems quite expensive to me. If I was paying for this myself, I probably would be thinking, well, I might be considering which was the best choice. I think on balance, probably aripiprazole comes out slightly ahead, but you will know better than me. So here's the question: why does this choice change over time? And it's a slightly stream of consciousness thing while I'm trying to work this out. Is it that we've got really unwell patients, and when they come in and they're in hospital, for example, and they don't have capacity to make their decisions, so we make it for them. Then they get better, and then they make decisions with us, and we as the specialists in early intervention guide them through, show them all of the options that they could take, and then they say, oh, I'm going to go with this one instead of that one. That's possible. And then the other thing is, if the patients in early intervention who we pick up in the community, who don't go to hospital, are they less unwell? So they've got capacity, and then they can go through that planning process and make their own choice. But I would say then, if patients are less unwell, if they've got capacity when they get better, and they consistently choose not to go on really sedating and metabolically active antipsychotics, why are we choosing this for them when they are unwell? That's the thing that doesn't make sense to me. If they're not going to want it when they're better, why would we put it on it in the first place? And also, presumably then, if they don't need to go to hospital, not so much they need to go to hospital, and they go to a community team, why are they choosing it? Why is that their preference? So, do different care teams have preferences for initial antipsychotic? They do. Why is it olanzapine is the choice? Well, we theorize that that's because of its side effect. If it's sedating, that can be quite helpful, especially if you're on a ward that's understaffed, we've got patients who might be volatile, overactive, and it might have a nice calming effect. The other thing that I wonder is it perceived as more effective? When patients are sedated, all of their psychotic symptoms become less visible because they're a bit, these are major tranquilizers, the original name for these drugs, isn't it? And they do tranquilize patients, so they can seem less psychotic, but they're quietly rather than noisily psychotic. Do they change over the course of that first year? Yes, they do. And they're less burdensome than side effects, i.e. the less sedating, the less they cause you to put on weight. I think those are the two big parts of it. The more likely you are to continue with it. And that's really important because you're going to get better outcomes. So, non-specialist teams are prescribing differently. And what should we do about this? Well, really, what I've done is I've taken it out to all of the teams in my trust. And what I've noticed is that I used to ask my students, what medication have you seen patients being prescribed when they're in hospital, and they'd always say olanzapine. And what I'm noticing now, which has been lovely, is seeing them saying a variety of different things, and that aripiprazole has started to crop up a bit more, which does seem to be more tolerable for our patients with first episode psychosis. But we do need to research a bit more about why it is that people are choosing this. I give them my theories, but that's what they are, they're theories. I need to go and find some evidence as to why people are choosing this.